Humeral head fracture. The anatomy of this injury is the humerus, head of humerus, anatomical and surgical neck of the humerus, greater and lesser tubercle or tuberosity. The pathology of this injury is when there is a break in the head of the humerus. It is classified as a part or type 1, 2, 3, or 4. Type 1 is the least amount of severe and 4 is the most. It can be either classified as displaced or non-displaced, in position or out of position. Approximately 80% of the time, it is a type 1 non-displaced humeral head fracture. Mechanism of injury is falling on an outstretched hand from a standing height or higher, such as on a ladder, a forceful blow to the shoulder, or car incident. Signs and symptoms include edema, ecchymosis, pain/point tenderness, limited range of motion, and obvious visual deformities. There is no special test for this particular injury, however, an X-ray is required. An MRI or CAT scan might further be used to determine if there's soft tissue damage. Predisposing factors include being an elderly patient. In patients 65 and older, a humeral fracture is the third most common fracture behind the hip and the wrist. Osteoporosis and bone cancer are also predisposing factors. Management and treatment include rest, X-ray, immobilization in a sling, cast, or splint, surgery if necessary, and physical therapy. Referral and immobilization are placed in a sling for 2 to 6 weeks, surgery if needed, and physical therapy. The PICOT analysis is determining which surgical procedure is the most productive procedure between a locked plate and hemoarthroplasty. The study had 122 patients of the age of 55 and older who went a 3-part and 4-part proximal humeral fracture surgery. There was a radiographic and clinical follow-up after the surgery to determine whether a locked plate construction or a hemoarthroplasty was the best conclusion. The outcome ended up being that the locked plate for both a 3-part and 4-part had better outcomes than the current treatment of hemoarthroplasty, and no time was presented.